So I'm going to go ahead and just get started with introducing myself and SunCloud Health, and then our esteemed speaker, Dr. Hien. Um, I'm Kim Dennis. I am a psychiatrist. I'm the Chief Medical Officer, CEO, and co-founder at SunCloud Health. We are a multi-specialty integrated treatment program in the Chicagoland area for people with complex co-occurring disorders. We serve adults and adolescents, and we have the whole array of levels of care, including residential care for adults, a newly opened residential unit for adolescents as well, and then three locations in the Chicago area as well for PHP and IOP treatment. Our patients typically have some way, shape, or form of combination of addiction, eating disorders, trauma. Almost 70% of our patients have meet full clinical criteria for post-traumatic stress disorder. And almost all of them also have a co-occurring mood or anxiety disorder. And we use, again, an integrated model using a unified team to help folks with complex conditions. And I would like to thank you all for coming today and being part of this webinar. I'm so excited to have met Dr. Denise Hien in Istanbul, actually, at the International Society of Addiction Medicine, and to have heard her talk there. And I asked her to come and give this talk today on the co-occurrence of trauma and addiction, which we see pretty much as a rule here at SunCloud Health. So let me go ahead and read the highlights from Dr. Hien's bio. She is the inaugural Helen E. Cheney Endowed Chair in Alcohol Studies and Distinguished Professor at the Rutgers Center of Alcohol and Substance Use Studies, Graduate School of Applied and Professional Psychology. She's also the former Senior Vice Provost for Research for Rutgers University New Brunswick Chancellor's Office. She's considered a leader in the field with continuous funding from NIH for over 30 years, and her body of work has contributed to the evidence base on the treatment of individuals with trauma-related psychiatric disorders and their comorbidity with addiction through conducting single and multi-site clinical trials across the US in community-based substance abuse treatment settings. Most of her funded research has focused on understanding and treating PTSD among women and underrepresented populations, primarily Black, African American, and Latinx women in Harlem, New York, with key goals of addressing health inequalities and understanding ways in which race, ethnicity, culture, gender, and other aspects of social identities influence the treatment and utilization and outcomes. In order to advance our field, she's been involved in numerous data sharing and big data collaborations, including the global collaboration on traumatic stress, an open science framework collaboration with Caltech and 5 other universities, Project Harmony, which is the largest data science project in the field that was envisioned and led by Dr. Hien. She is board certified in clinical psychology and serves on numerous national boards and scientific advisory boards. She is a distinguished scholar and leader in this field. I'm so honored to have you here today to share your expertise with us. She's going to give us her talk for about the next hour, 10, hour, 15 minutes, and then there's going to be ample time for questions and answers, which you can utilize the Q&A box or the chat box to ask your questions. And without further ado, I will turn it over to you, Dr. Hien.
Thank you so much, Dr. Dennis, for that lovely introduction. And also, it was a pleasure meeting you. And Istanbul is quite a place to visit. And so is the International Society for Addiction Medicine group. But I'm delighted to be here to talk with you guys affiliated with SunCloud. Are you able to see the slides? Just making sure. Okay, great. At SunCloud. And I just wanted to earmark the fact that though there are more and more programs around the country that are addressing comorbidity treatment exclusively, this is relatively rare. And, I also do international, am invited to give talks internationally, and it's very unusual to have this kind of treatment program at such a high level as SunCloud. So I just wanted to say I love the fact that I get to come and talk to you about my passion over my entire career, which has been understanding more about the relationship between traumatic stress and addiction. But I also know that I'm speaking to a very experienced, sophisticated crowd. So I look forward to, I hope I will have some new things to bring to the conversation, but just wanted to acknowledge that. And, with that, I also wanted to say that I don't have any disclosures, except that all of the research that I will be talking about has been funded by the National Institutes of Health. I also I often do a land acknowledgement in this space, which is really to both recognize that a lot of the work that has been done in the United States has been on land that does not was, originally from the indigenous peoples, and in New York and New Jersey, it's the Lenape people. And, you know, because a lot of the work or most of the work that I have done has addressed underserved populations in New York City and in the region. And so many of the people that we know across the country that have been unduly exposed to traumatic stress and addictions are from underrepresented, diverse backgrounds, and who have also been participants in our research. I always like to take a pause and say, and make that acknowledgement, um, because I think the work that we all do, the work that we're all committed to doing when we work with comorbidity and trauma recognizes the needs and all of the social determinants that bring people into care, and all of the barriers and challenges to providing care. So even many of the things that I'm going to be talking about in the talk, we are now thinking about, like, how do we enable people to gain access to the evidence-based treatments that we now know can work. So it's a positive, message that I'm bringing overall. Although, we're recognizing that there's lots of challenges and barriers that we all deal with when we work with our clients. But to just start with, I wanted to acknowledge the lived experience of people who live with both traumatic stress and traumatic stress related disorders and addictions. And these are some of the words from participants that we've had in our research. I know it ravages my life, but when I'm high, I don't have to feel it. The trauma in my body and my soul, I can disappear a few hours, a few days, a few weeks, a break from those relentless memories. Well, at least I know exactly how I will feel when I use substances, good, bad, or ugly. Otherwise, I'm all over the place. So that sort of really speaks to, some of the reasons that people use substances to help manage the pain and symptoms of their traumatic life experiences. And so in this talk, I'm going to focus on a couple of different chapters. I'd like to sort of organize the talk. One will be the kind of comorbidity and consequences that I think most of you will know very well, and I'm going to go through rather quickly. Then talk about kind of the body of the science on integrated PTSD, SUD care, and what we've learned in the last 20 to 30 years of clinical trials, and then speak a little more clinically to what we suggest to be an integrated framework for care, and then finish with time for questions. So first, when I first started doing this work, we had recognition of some of these things, but a number of our national epidemiological studies have really helped to narrow in on rates and numbers. I don't think I have to tell you guys that we have a huge problem in our country of over 48 million people who have substance use disorders. And this slide is really just to show you that the vast majority are actually not receiving any substance use care. And there are reasons for the fact that people don't receive care. Some of them have sought treatment and don't have access to it, or there have been all kinds of barriers. And then a lot of people, didn't seek treatment even though they might have recognized that they needed it. And things like stigma, not having, kind of the feeling of shame and things like that are many of the reasons why people don't get care, in addition to the fact that it's an unaffordable situation for many people. But then there's also a very large group of people who do not perceive that they have the need for substance use. And so more recently, there's been a real push to get more kind of addiction care into primary care settings and low barrier settings where people who use substances or people who use drugs who may not need, may not wish to stop using or adopt a full abstinence model, but still, are out there and potentially accessible. So, we all know about the opioid crisis and deaths from the opioid epidemic, and this is just one curve. And basically, we know that I think about 100,000 people have died in the past year still, but that it's starting to peak. And with the big public health effort to deliver medications for opioid use disorders, there's been a kind of a turning of the tide in terms of that crisis. But and so that's good news, but the not so good news is that that's not true for all racial and ethnic groups. So it is true for white people, particularly white men and white young men, where, the rising rates have affected so many families across our country, and really raised a level of awareness of, and also have, I feel, brought a much more public health and medical model kind of perspective to this idea that people can have that addiction is a disease, and from the point of view of a chronic health issue, and that it can receive treatment, and there are medication treatments and things like that. Unfortunately, that hasn't been the case for anybody who isn't white. And the rates, if you can see this curve where they're sort of starting to go down for the white population, there's a very steep incline that continues to increase. And I have to update my slide now because there's better visuals for this, but showing that in African American and Latino populations, the numbers are still rising. And certainly things like crack and fentanyl in the mix, and the other wave opioid mixtures are leading to just as much death in certain communities. So we certainly have more work to be done in that space. We also do know, and again, you guys don't need me to tell you this, that most people who have a substance use problem also live with a mental illness of some kind, and typically more than one. And I'll talk a little bit more about that. But, since the topic of this talk is about traumatic stress, I would say that we know, in terms of the kinds, this is not an exclusive list, and I'm not going to read every single thing on the list, but essentially people can be exposed to trauma in many different ways with many different, types of trauma, whether, we first thought about trauma and PTSD from the point of view of disaster and war. Since the 1980s, late 1980s, the DSM-3R changed the diagnostic criteria to think about interpersonal violence as being like what we call a criterion A or a traumatic stressor. And so that opened the door to thinking about physical violence, intimate partner violence, and other kinds of sexual violence as traumatic stress exposures. And what we know in the world is that traumatic stress is many people, most people are exposed to at least one, if not multiple different types of trauma in these categories over the course of life, which is part of the reason why when Dr. Dennis was, introducing your program, basically saying that, that everyone who comes to your program nearly would classify for one or more types of these types of trauma. And this does not also include, kind of the kinds of I don't even like to use the language of big T, like big traumas versus little t, but there's interpersonal trauma of the kind of what's going on in family dynamics or witnessing violence or things like that that are also could be very traumatic in many different ways. But we do know that most people who experience trauma in the world do not develop a comorbid mental health disorder. So there is something about our, you know, just the human condition where, we went through the pandemic and went through many things that were traumatic, but our population tends to be pretty resilient and somehow we navigate through, unspeakable things and horrors, war and so on. But we also know that for those who have been exposed, the likelihood of developing something like post-traumatic stress disorder and or other comorbidities in addition is higher, and it is higher for women than men, even though men are more likely to be exposed to severe traumas or different types of traumas. You might be surprised about that, but their rates are, a lifetime prevalence of 5 to 6 times. It's 2 times more for women. So if you're working with women or gender diverse populations, we often see, much higher rates of PTSD, and it's a significant problem for the United States. It's also a significant problem in the rest of the world. And there's a number of risk factors that, increase your likelihood of developing PTSD, including if you were exposed to trauma as a child and have an ACE, an adverse childhood event, like even parental divorce could be considered an ACE. There's lots of things, including some of the traumatic events that I showed you in the list before. But whether or not you have a social support system, all of these things can increase your likelihood of developing PTSD. And also there can be, mental illness in the family that can increase the rates. And then just in terms of the symptoms, I'm not going into the DSM-5, but just to say that one of the hallmark symptoms are the kind of intrusive thoughts, the idea, nightmares, or, people trying to push away the memories of the traumatic event, but being haunted by them. And that's sort of one of the intrusion symptoms, or the remembering symptoms, are the ones that we think of when we think of post-traumatic stress disorders. We also have changes in our physiology and neurobiology, which I'll speak a little bit more about in a few moments. Changes in our mood. And so all of these different symptom clusters in the PTSD framework, including avoidance and, lead to a picture of something called post-traumatic stress disorder. I think other than acute stress disorder, I think it may be the only diagnosis that has an actual event that occurred that is part of the diagnosis. So something had to happen to you for you to develop this disorder, and that is not in any of the other nomenclature of any other diagnoses, in the same way. So I take that into consideration. I also tend, I'll just say, like a lot of the clients that we've worked with probably could meet criteria for borderline personality disorder, and it may be useful to think about personality features, but I tend to think about PTSD and also complex trauma, which I'll show you also in a moment, um, more than conferring a personality disorder diagnosis. And part of that is because you develop these things as a consequence of things that have happened to you in the real world, like, that are concrete. So, but we expect to see that people will have a duration of at least a month of functional impairment if they have these kinds of symptoms. But the person's experience of PTSD I think of it as an emotion dysregulation problem. Like there's hyperactivity of the HPA axis system and arousal. So people are very jittery and jumpy on the one hand, and then there are other times when they're depressed and numbed out and don't think of having a future and kind of start shrinking away from all their relationships and friends and families to sort of avoid anything that triggers and reminds them. Lots of avoidance symptoms, and avoidance can also be the use of substances, which we'll talk about a little bit too. So on the flip side, in people who have traumatic stress, we also know that the substance use and misuse is the norm rather than the exception. I have this elephant here because oftentimes people don't talk about it, and providers who work with mental health and work with trauma don't necessarily think to ask about use of substances. Again, I don't think I have to tell you guys about this, but we really recommend that whomever you're working with, whether you're working with someone who has a substance use problem, or you're working with someone with trauma and traumatic stress, it certainly would benefit also doing an assessment of the other condition, because so many people, it's not just like a few, it's, pretty much half will use substances in a way that potentially could be a misuse problem, if not a more severe problem. They won't necessarily talk about it. So if you don't talk about it, you don't ask about it, you're not going to necessarily find this out. In terms of the epidemiology, and this comes from the epidemiologic catchment area study first, and then NESARC has, done a lot of work to kind of underscore that no matter what population you're looking at, we're going to see a lifetime prevalence of disorders. At least 40% of people with PTSD in community samples, in treatment settings, will meet criteria for at least one, if not more, substance use or alcohol use disorders. And likewise, for PTSD, for people living with substance use disorders, very high PTSD prevalence, if you just ask. And then to the right here, we see that really for men and women, if you have one disorder, you're more likely to have not only two, but three. So the majority of men will meet criteria for three other, diagnoses: PTSD, substance use, and maybe a major depressive disorder. Same for women, although a slightly smaller percentage, but really it's just worth. And then I also like to say in this slide that it's not just the psychiatric conditions that we're dealing with. We're also, if you start talking to people about medical conditions, dental issues, we're dealing with a population that avoids doctors for lots of good reasons. And so they tend not to, when we're working with someone and helping them through their PTSD and substance use, we also really should be thinking about the whole person and physical issues. So many people with sexual abuse histories just haven't gone to doctors or have been traumatized by their interactions. And so helping people in those domains get healthy in body and mind is super important. And so here, this is like, what's the relationship with PTSD and SUD? And when I first started doing this work, we knew that there was a correlation. We knew that a lot of people who, if you worked in a community substance use treatment program like I did, you would see so many, any of the women that came in, they all had trauma histories and many of them had PTSD. And so, but we didn't know like what caused it. So the idea was, could it have been sort of the high risk lifestyle of a substance user that, if you're a woman, you use substances, you might be in partnerships with people who use substances, there might be drug dealing going on, you might be victimized more likely because you were under the influence, or because you were just exposed. So, maybe that was the cause, was just if you treated the substance use, maybe the PTSD would go away. We also had the sort of parallel question or idea about, the self-medication model. Ed Kansian and others in the psychoanalytic space. It talked about, the affect and developmental regulatory issues in people who have substance use, and that maybe, people are using substances to manage their PTSD. And so then there were a bunch of different large scale studies. Some were the genetic twin studies done by Ken Kendler and others, the ACEs study, which was the public health done by the Centers for Disease Control, and it was just looking at morbidity and mortality in, the population of the United States, and finding that, oh, adverse childhood events actually predicted all these negative outcomes, including substance use. And then there were also a bunch of studies that actually specifically tried to look at which hypothesis was sort of the driving factor for understanding the relationship with PTSD and SUD, using like data from health records and insurance company data. And, so now we know that basically, obviously, everything is more complicated, and there's always multiple reasons that people might develop and any kind of mental health and substance comorbidity. But it's really the self-medication model that shows that early childhood trauma exposure more often than not leads to substance use, and the increases the likelihood of developing a substance use disorder. Now, that doesn't mean that everyone who's been traumatized develops a substance use disorder, but there's actually a science behind this that suggests that there are shared genetic factors. There are overlapping neurobiological effects. So we know that in substance use, the reward system of the brain is impaired, and we also know that, like, if once you start using substances, and George Koob and others have talked about the kind of the kind of negative reinforcing. So first you start using and you get positive reinforcement. It changes your mood. It elevates, and so you get more the high feeling, the positive feelings. But over the course of time, there's actually a neurobiological change that he refers to as the dark side of addiction, and it's really that you start having more depression, you start having more negative affects, and then you are using just to get yourself back to a more baseline state. And we know this from working with people with substance use. And so the regions of the brain that are involved are actually very similar. So for people who have PTSD, it's the limbic system and the amygdala and the fear response system that is involved, and similarly also involved with the dark side. So just that's sort of an oversimplification, but essentially we know that there's a neurobiological impact and driver of addiction. There's also a neurobiological impact of trauma, and there's been a ton of animal and human model research to show that. And then we have early life stress and personality traits. And so I use this slide to kind of say it's a complicated problem, and it has biological aspects to it. It also has psychological aspects to it and genetic. And so it really takes a team. So like a program like SunCloud that has a team approach, you really need to bring everything to bear to address the issue. And I'll show that to you in terms of just being able to review the body of science on treatment for these conditions. But before I go there, and I had alluded to this before, the concept, not only do we have in DSM, in the DSM system, we have the concept of PTSD. In the International Classification System of Psychiatric Disorders, or the ICD, we also have the concept of complex trauma, or some people refer to it as CPTSD. And I bring this to you guys because in our experience of working with people who have comorbid PTSD and substance use, it is just what you see when you're working with people. It's not just the symptoms of PTSD that I was just talking about, but it's the developmental trauma often. There's if you think about disturbed attachment and interpersonal problems that we see in a complex trauma framework where, the person very early on, there are issues and disturbances in the capacity to trust. If you've been sexually molested, or bad things happen to you in childhood, it's hard to, engage with others. And so it affects your learning, it affects your schooling, it affects your development in many ways. And those can lead to problems in emotion dysregulation. Again, those problems in emotion dysregulation can also be driven by some of the neurobiological impacts. If you're living in children who live in chronic stress, it changes your hypothalamic pituitary adrenal axis, or HPA axis, your fight flight response. If you're always on and you're always like, looking for the next predator to come after you, it turns on all those systems in your body, and that has an impact downstream in terms of like on your ability to self-regulate. So we see that a lot with our clients. And of course, substance use is one way to dampen that hyperactivity and noradrenergic activity, to use those terms. And then we also see a lot of dissociation. We see a lot of shame and guilt, which is now part of the new DSM-5 cognitions issue. But I think we also, when we work with people with PTSD, a lot of the work is not necessarily about the symptoms, but also in the guilt and the shame and self-blame that that come out of these confusing interpersonal traumas. So I did want to mention that. And this is also where I say, like, I feel borderline personality often, it's a useful framework, but it often puts the sort of blame on the client as opposed to what's happened to them. And so that's why I tend to maybe use the ways of thinking about the trouble that people get into behaviorally. But I feel like it's more helpful to think about trauma and complex trauma when we do our work. And I have many good friends who are personality disorder researchers and very excellent clinicians. So I mean no, I'm not casting shade. I'm just saying this is sort of my thinking about that. So what we know in terms of treatment is that obviously co-occurring PTSD and substance use are highly impactful, and it's a real problem. And of course, when you have more than one diagnosis, you are likely to have more problems. We also know that people who have both conditions have more psychiatric issues, like I said, more severe, and then they're also potentially less likely to seek help and may not make it through as many sessions of treatment. And also, our treatment systems are not super friendly to people who are erratic attenders. And in the addiction field, it's like, three strikes and you're out. And I understand from a clinical perspective, it's very hard to treat people who are sort of unreliable in their treatment participation. But I just put a plug out there for the fact that it's really hard for people to get to treatment, and when they have more barriers, and if they're, of course, women or, responsible, have childcare, family responsibilities, all these barriers make it hard for people to attend. So whatever we can do to have a compassionate point of view and not be so quick to say, well, if you don't come to your treatment, you're out, or, that having this idea that you have to get every session, otherwise you're not going to get better, because we just don't see that in the research. And I'll talk a little bit more about that. So, I do want to make a distinction when we talk about, this body of, whoops, let me go back. This body of this section of my talk, that we have this idea of trauma-informed care that everyone speaks to. It's very good that people speak to this and are thinking about this. This is from the SAMHSA, kind of has, sort of spread this around, like the idea that when we work with certain vulnerable populations, we should know that many or most of them have trauma. And so we provide trauma-informed care, which kind of speaks to all of the soft signs of, and I know your agency, that SunCloud does this, and many of the great treatment programs do this, is like you train your staff from the van drivers to the receptionists to the practitioners to the, everybody who works in an organization, to the fact that there should be certain, practices that are sort of compassionate and recognizing that you're working with a traumatized population. And so that's not what I'm talking about. I think that's just good treatment for anybody. Like, we should all be just sort of aiming to have that type of informed approach to when we work with any human being, whether they have a technical trauma or not. But we do now have a body of work that has shown us kind of basic principles for specifically PTSD and substance use. And so I'm showing you here like a theoretical model that has been the most widely one that's applied to studying PTSD. And I'm not going to get into all of the details of this slide, but basically to say that the behavioral treatments that I'm going to be talking about and speaking to, basically conceptualize trauma as like a traumatic event occurs, and then, between, there's like some set of mental representations and also fear networks that are, established, that could, be both cognitively driven as well as kind of in the neurobiology, that the person develops these kinds of fear networks that are associations to, traumatic things. And then what we see, what we see is that that leads to avoidance behavior, and the avoidance behavior can then develop into PTSD. I'm clicking here because one set of avoidance behavior can be substance use. And then there are cues that are both internal and also external that bring the person to having their symptoms kind of flourish, and then also to engage their fear behavior. And some of the treatments focus on what we call the top-down approach, which is, and this is specific to behavioral interventions like cognitive behavioral therapy. The top-down approach is like cognitive processing therapy, work on changing the person's thinking about, like, this traumatic thing happened to me, it was my fault, and I can't go out of the house because I'm a bad person, and, bad things are going to happen to me again in the future. Kind of tackling those kinds of faulty cognitions to help them change and reduce these kinds of behaviors and triggers. The bottom-up approaches are the things like a prolonged exposure, where you're basically putting the person in the fear, helping them to connect to the fear network, helping them live through the fearful experience, and realize that by dampening that if they allow themselves to process the fearful feeling, they're not going to have more and more fear. They're going to have less and less fear. And that's sort of similar to the concept of urge surfing in the substance use field, where people are afraid that if they once they have cravings, they have to use. But what we try to do in urge surfing is help them ride the wave of their craving to enable them to gain control of it. So these are behavioral cognitive models that have been applied to PTSD very widely and shown to be effective. And I'll talk a little bit more about that. But we also now have these models in our thinking about how to treat PTSD and SUD. And so what we know from the PTSD world, and the idea is that there are different types of treatment. So Judith Herman wrote about this in her book, like, this idea that there are stages of treatment. And so the first stage, this makes sense to everyone, is stabilization. And that's, when somebody's got a dysregulated life, we want to focus on psychoeducation and skills training. So a lot of people get DBT or things that focus on affect regulation and distress tolerance. That makes sense, right? If people are dysregulated, we want to kind of get them more stable. And then the second phase of trauma therapy would be to process the treatment or do trauma-focused approaches that would help process. But we wouldn't want to do both. We wouldn't want to start trauma processing before we had done stabilization. And this is for people with PTSD, and we're not even thinking about their substance use. But when we then think about substance users, the belief for many years was that you can't treat the PTSD. You can't even go to any kind of processing therapy or the things that work to help drive down the PTSD because the person will relapse. And you would have to wait until they're absent. And so a lot of mental health places would say, sorry, you have to go over there and get your substance use handled first. Well, the problem with that is that what we have learned is that siloed care can be harmful. So, and I'm not talking about like maybe the person who's coming in who has a substance use problem and is in withdrawal and they need a detox or they need to be tapered onto something like buprenorphine to get themselves stable. I'm not talking about that level of stabilization, but I'm saying that the idea that the person has to really have their substance use cured or treated and be abstinent before we can start doing comorbidity. And I realize I'm preaching to the converted here, but that's not a helpful model. And for PTSD, SUD, it's really harmful. Why is it harmful? Well, you remember that I just showed you that kind of the pathways, slide. If we know that trauma is driving the substance use and that people's PTSD is what leads them to use substances, then first of all, expecting them to be able to stop using and then that their PTSD will improve. No, we don't see that at all. We see it usually worsens. And also it will be more likely to potentially leave treatment if they can't get the care that they need. And so now we have a whole boatload of intervention trials that have essentially, I'm going to summarize in a couple of slides, but the fact is, the good news is that concurrent care is safe and effective. And so we can do skills-based interventions, and I'm just putting one example. Seeking safety model has been tested the most widely. When we first started doing our research work, we used seeking safety because it felt like that was a treatment that we could feel confident would not harm the person. So we didn't originally start doing trauma processing. We were really going with the phase-based model of Judith Herman of like start with the stabilization. And we were able to show in various trials that that the seeking safety model could be done, that people in treatment programs could be trained at all different levels in community drug treatment, and was well tolerated. More recently, more studies have been done that showed that You could do some of those more trauma processing models also safely, like we were not seeing adverse events. And so COPE is it's a concurrent treatment for PTSD that uses prolonged exposure, which is one of these top bottom-up approaches, which is you get the person to talk about their specific trauma and relive it in the moment and sit with that. And there's a whole structured approach for doing it. It could be anywhere from 12 sessions. That's just one example. EMDR is another example of a trauma um, processing therapy that we have seen now done with substance use populations. And so there's a bunch of trials that we can speak to that really show us, and this is just one example. Sonia Norman and colleagues, this was published in JAMA, but compared the skills-based to the trauma processing therapy. So this was seeking safety compared to COPE, and what you can see in terms of the overall PTSD scores during and then after treatment is that there's a superiority of the blue, which is the trauma process, or sorry, I'm sorry, the it's lower rates, and so this is superior of the trauma processing therapy, which is the yellow. But so this is integrated prolonged exposure. So that COPE model compared to a seeking safety model significantly better in terms of outcome over up through a 6-month follow-up. And so here's the question back to that other slide of, should we wait to treat PTSD when we have people who have PTSD and SUD? And the answer is a resounding no. And I will say that, like, still I hear people sort of be very reluctant to say yes. When you have a patient and you see that they have both, there is a tendency to feel like, well, we've got to get them stabilized in some way. So, and I recognize that every case is different, and so people have to the team should make their best decisions on when, but all the clinical trials that we've looked at, which do not have the benefit of like doing it in the clinic. So these people are entered into the trials with their severe symptoms upon diagnosis. So like, a week or two after they've been entered into a program, they are starting these treatments. And we have not had any evidence of any serious adverse events that have come from them, and quite the opposite. So we can confidently say that these combined treatments are tolerable, safe, and effective if you're using some of these evidence-based models that have been tested. And we see also, this is really important, that when you target the PTSD and you get those reductions in PTSD, substance use will improve. So, we always work in a harm reduction framework, so we're not expecting to see people jump into abstinence, but over the course of time, we see the substance use symptoms come down, and they only come down when we've gotten a handle on their PTSD. And so some of these findings, and we don't see it for the opposite. We don't see like driving the substance use and getting substance use totally handled will completely clear up PTSD. So that's, very important. And just to drive that point home, I'm showing you one set of analyses that we did on a trial comparing the COPE treatment, which is a trauma processing therapy that's integrated with substance use relapse prevention, compared to relapse prevention by itself. And everything in the blue is relapse, people in relapse prevention, and everything in the, lighter colors, red colors, is COPE. And what we wanted to see was like, does it matter which type of treatment you're getting if you're actively using substances during treatment? So like while you're receiving the trauma therapy, what happens to your substance use? And what we see in this curve is what happens to your PTSD. We see in the curves, everybody is getting better over the course of the treatment, which was 12 weeks of individual therapy of the trauma or relapse prevention. Everybody gets better. The gray box is people who are getting clinically significant change. So where they are like having very few symptoms or, a significant reduction in their PTSD. And so you see by the end of treatment, who gets into the clinically significant change range and then over the course of the follow-up period is the people that got the trauma processing, not the people that got the relapse prevention. So the only focusing on their substance use, like don't address their trauma, just focus on their substance use. They got better. And then the two lines that we really want to look at are the top line, which is the people that were using actively during treatment, so 4 times a week or more. The people that got relapse prevention, you see, they just don't get near the clinically significant change, the clinically significant, reduction. Whereas the people who were using 4 times a week or more have the greatest amount of reduction in their PTSD. So, what this suggests is that it's safe to do trauma processing. And not only is it safe, but if you really want to move um, the dial on the symptoms that the people are suffering from, even for the ones that are using the most, you need to be addressing their trauma in an active way. So back to that stage model slide where it's like skills-based versus trauma processing with the idea that you got to wait, everything has to be sequential. We're just not seeing that in the data. And then just to, add to the picture, we have now also, so what about medication? So I've been talking about behavioral interventions, and I will be putting this all together for you in the next few minutes. But and when it comes to medication, we have fewer trials out there, and we have those that have targeted agents for alcohol and substance use, like medications for opioid, buprenorphine, Sublocade, naltrexone. We also have medications that target substances in terms of, agonists like, benzodiazepines for withdrawal or aversive agents like disulfiram. And then finally, agents for PTSD alone, like SSRIs, sertraline and paroxetine, agents targeting both. So using certain agents to kind of target either the sympathetic arousal that we talked about or some extinction learning or HPA axis dysregulation. There's only 14 clinical trials that have been done with pharmacotherapy and for PTSD, SUD. And what I can tell you, and so here are some of the agents that we just talked about. We don't have any clinical guidelines in terms of best medication profiles. We do see that there's significant reductions when we try, in both PTSD and substance use, and that there's importantly no evidence against using these medications for people who have comorbidity. There's no evidence that they make people worse, but the jury is still out on what agents are best to do. And it's been very hard to get these trials done. And having done one of them, I swore I'll never do a clinical trial with a medication as a psychologist ever again, because it's so hard to do. It took so long. So kudos to Ismini Petrakis and all the people out there who've been doing these clinical trials. But we just don't have enough information, but we do have enough to know that you can treat symptoms for people with comorbidity. And we know clinically that all of the clients that I work with clinically are always getting psychotherapy and some kind of pharmacotherapy. And so the good news is that this is just showing you that there's a bunch of things in the pipeline and that there's been a real groundswell in more clinical trials in this area. And so, the jury's still out, but it's coming. And so the final set of slides from this, basically, how do we evaluate the body of work the evidence base that has happened so far? How we can evaluate it is that, most of the impacts that we've seen are directly impacting PTSD, and then we're seeing later impacts on substance use. But we can treat people safely, and we can do these kinds of interventions. But the intervention trials are, have various limitations, and we haven't really been able to do the question of like, for whom do the treatments work best, for whom do they not work as well, because the trials are so hard to do and they take so many years that you get a lot of dropout. People, just don't stay through. This is true of all clinical trials in addiction, but it's even more so when you have a comorbidity. So the literature base was still, kind of like we couldn't make the best clinical guidelines. And so we created a data science project called Project Harmony, which was first funded by NIAAA, and now we have gotten more funding from NIDA to create, our goal was to acquire every data set we could of anyone who tried to treat PTSD and substance use, and pool the data so that we could answer the question of comparative efficacy. We could say, which types of treatments work best and which don't work as well. And putting it all together, we're using a data science approach to do that. So without going into a huge number of details, which I feel will take us off the course, this is a multi-institutional collaboration. Currently, we have 42 studies that we've acquired and harmonized. I'll tell you what that means, with over 4,500 participants. Most clinical trials in this field only have maybe 100 randomized to 2 arms. So that's just not a lot of people in any given one trial. So we're getting power by using these data approaches to answer questions. And so I'm just going to give you the highlights of what we know. And these are some of the members of our team, our executive team from the institutions I just showed you. And we also have a bunch of early career investigators who are with us. And it's an international effort. And so unfortunately, all high income countries that have the money to do these kinds of trials. So we're missing low and middle income countries in our data set, but we do have involvement from all over the world. These are all the PIs that have generously shared their data with us, and we have an international consortium that we've brought everyone together and keep them informed on what we're doing. And so if there are any of you out there who'd be interested in, our researchers would like to join the consortium, you can reach out to me. But so we call Project Harmony a virtual clinical trial. And I'm not going to spend a lot of time on all of the methodology that makes it a special thing, but we basically are trying to answer questions of which treatments work best for which clients. And we have so I often say it's like the iPhone, the little wand on your iPhone. When you click on it and the photograph just pops, that I feel like this methodology has helped us do that for the field and answer certain questions like, are the non-integrated treatments or the skill-based treatments better than the trauma-focused treatments, the processing treatments? What about if we add a medication into the mix? Which types of medications seem to be best? If we are comparing every treatment that was done to what we call treatment as usual or a placebo, so because many clinical trials are done and they always have different treatment, you're comparing different treatment to one another. So it's hard to like look at the entire body and of literature and say, which one works the best. And then we've done all kinds of other statistical tests to enable us to do these kinds of comparisons. And so these are all the different types of treatments. And we've looked at, all the studies that did alcohol or drug targeting medication, those that did PTSD medication, those that did combination of the therapy and the medication. And what we found is really good news for everyone, which is that there are no wrong doors. So amongst all of these different types of treatment, so cognitive processing treatment, cognitive behavioral therapy, relapse prevention, the seeking safety model, all of these kinds of interventions, on balance, everyone gets better. So we're not doing harm by doing whatever treatment model we're doing to try to address the trauma and the substance use. But some are better than others. And the big winner is the combination of trauma-focused therapy with an alcohol targeting medication, or a drug targeting medication. And the effect sizes are very large. So I like to say, if I have a family member of my own, and I was going to say, of all of these types of treatments, which treatment would you want to send your loved one to? It would be a trauma focusing therapy like EMDR or prolonged exposure or COPE or cognitive processing, any of those that really delve into the trauma, combined with a medication like topiramate or naltrexone, just as examples. So we have the findings, they're in the, they've been published, but and what we know, and I'm going to move through these quickly so I can get to the last section of my talk and leave us time for some questions. That, this again goes back to those treatment models that we were talking about earlier. We see that decreased PTSD severity leads to lower drug and alcohol cravings, and that trauma-focused treatment, anything that targets the trauma symptoms, decreases the PTSD severity and lowers alcohol and drug severity. So it's just another way of, we've done these analyses with these treatment samples. They've also been done with epidemiological samples. And there's no question that if we give our patients the best care we can for their PTSD, that we will also see benefits long-term. And for those with alcohol, we saw direct benefits. So they, in the Project Harmony analysis, we also saw that alcohol was directly impacted, but drug use we saw come down over the course of time. So there was a mediated effect. So you really needed to see the trauma symptoms come down in order to see the effects on drug use. So then the last section of this is really to just talk about, okay, forget about all the clinical trials. Like, I think they are providing us with kind of like a lighthouse beacon of, okay, what directions can we go in? And we don't have to be afraid to roll out the kinds of evidence-based models that we have for PTSD and that we have in terms of medications. We can give them to our patients. Our patients are not so fragile. They're pretty strong, if not very strong, and they can tolerate and handle what we have to offer them if we believe it. And I think at the moment, our bigger barrier, besides the dissemination barriers, is, do we believe that these things, we're not going to harm our clients by helping them to process their traumas? And the scientific evidence is very clear. We're not going to harm them. So we can use whatever the gold standards are for trauma treatment, we can use with our substance use clients if we can get ourselves trained, if we can overcome our own barriers. But there's also, like, you when you're working with your client, like any good clinician, what does success look like? Symptom reduction is not the only way we measure success. Obviously, wellness, well-being, other recovery outcomes. Many of our clients are not, their goal is not to stop using 100%. So can we work with them in a harm reduction framework? And then, what do we do if our patients get worse? And so, what I like to say to practitioners is like, we just want to be drawing on our best practices of using an integrative framework when we work with people. We want to be doing excellent assessment. We want to be using motivational interviewing and harm reduction, and integrating those kinds of approaches. We want to be thinking about the therapeutic alliance, going back to that point about interpersonal trauma and trust issues and compassion, and then we want to be doing all the models that we can. And these are some of the things that we can use to help with the skills training and trauma processing that you're implementing with your clients. And I also understand that in many, many clinical programs, you don't have the resources to provide individual therapy for everyone. So there are ways of delivering in group, like cognitive processing therapy can be delivered in group. So they're not sharing their traumas and triggering each other, but it's more of a, personalized, you write a narrative that you are working on in group. And then written exposure therapy is another group model that people are starting to try to implement. So once the field was able to say, listen, we can treat trauma safely. We have seen in people with substance use, we've seen people trying in clinical trials all different things like mindfulness-based approaches and best practices for people with PTSD in substance use populations. And so the next body of science is going to be showing us the impacts of those interventions. And that's what we're going to be working on in what we're calling Project Harmony 2.0. So in terms of treatment planning, multi-domain assessment. So I'm telling you things that you guys know, but like the integrated care, coordinated care, team approaches, helping people with their social determinants and promoting stability, working on the sort of 8 dimensions of wellness model of spiritual, occupational, financial, not just thinking about symptom reduction, but also all the dimensions of a person's life that are important. And like I said, I think in the science part of it, where our job is to study how do we implement and disseminate these things. Can we work on, we don't have any practice guidelines for PTSD, SUD still. So I'm working on that with my trauma colleagues, but there's more work to be done in that space. And then also more international work and data science projects. So in conclusion, what we said, highly comorbid and untreated, we can do it. We have to do it. And individual care, care that's high quality and should be individualized and, be client-centered and comprehensive. And I thank you for your attention. And also to everyone who I work with who's contributed to this body of literature. And finally, I do have a new book. So my people are always like, you have to put that in your talks. But it is an integrative guide. So it gives, it's a very clinically focused book. I think it's also great if you're doing training and supervision. And we have clinical cases that are composite cases that are embedded through. And at the moment, it's, hot off the press this past year. So if you like what I've been talking about, it's probably a good book to take a look at. And with that, I will stop sharing my slides.
Wow, thank you so much, Dr. Hien. And also thank you for sharing your book.
Ah,
Congrats.
thank you.
That was really outstanding, and I loved so much of what you shared. Any of you who have questions, feel free to put those into the Q&A box. We have a couple so far. I can get us started off. Just in general, I'm struck by the still this idea that seems to be pretty pervasive out there that somehow asking about trauma, doing trauma-focused therapy is dangerous and is going to cause harm. And the pervasiveness of clinician avoidance. The avoidance symptoms that clinicians
Mhm.
have,
Yeah,
which parallel really a lot of the avoidance symptoms that patients have. And
yeah.
if you have any thoughts about helping clinicians get over the hump on their own avoidance, beyond the data, which I think is, it's hard to argue with data, um,
Yeah.
right?
Well, I think that it's a great point. And yeah, I mean, first of all, when we do the trauma processing therapies, we have to do our own, soul searching, because your job when you're doing it is you don't actually have to do all that much. You have to sit and listen. Like once you learn, for example, prolonged exposure, it's the job is to sit with the patient or participant who is relating the most horrible thing that has happened to them, and you have to sit and listen and bear witness to it. And I think that that's just very painful to have to face what someone else has gone through and to live through that. So we have to be prepared for that and do our own work. And so I do think that, people should have their own supervision, or, in my case, I've had a long-standing peer supervision group. So you can find ways of and even our people who do assessment for us, in our research, like our graduate students and others who do the clinical assessment, are listening to very traumagenic material. So there's that part of it, is like our own vicarious traumatization and also fear that can come from that, which I think sometimes we maybe put on the client, but really are not noticing that we're maybe avoiding things ourselves. So good supervision and training goes a long way. And if you can't get it at your organization, putting together a peer group has been very effective for people to be able to get support. But then also, I feel like it's important for me to do the talks, and for my colleagues also to be doing these talks. And we have similar things going on in the VA as well, where we're just delivering the message that you can do this safely, and if and then when we're doing it, it's so powerful. When I'm doing a clinical trial right now in with intensive uh, prolonged exposure, where we're doing it in 3 weeks as opposed to over the course of like once or twice a week for a number of months. We're doing it 3 to 4 times per day per week. And so you can get it done and what's it's called mass prolonged exposure. And am working with a substance use treatment program, and they have come full circle because they're seeing the therapists themselves, who are the therapists in the programs, are seeing how much it impacts so quickly your client. So once you've actually tried it and done it, you don't have as much problems getting buy-in. It's just before.
Yeah.
Yeah.
Yeah, I mean, that's the experience we've had at SunCloud with cognitive processing therapy and really fully integrating it into our clinical work. Once the therapists see the striking drops in the PCL5 and the patient doing so much better, that it begins to sort of sell itself and the fears tend to die down.
Yeah.
Related to this, when it comes to burnout, clinician burnout, in light of the emotional aspects and the emotional heaviness of walking with someone who's facing the worst things that have ever happened to them in their lives. Any tips for clinicians who are doing this work to um, protect themselves or to keep themselves from reaching a point of burnout?
Yeah, well, that it kind of goes back to the point about getting supervision and, or doing, your own self-care and wellness activities, recognizing that you're vulnerable. And so, it's not a choice. It's really a must. If you want to do this work and you're committed to doing this work, you have to be doing your own wellness work as well.
Yeah,
Uh, and so whatever form that takes, just having that awareness is really important.
excellent. We have a couple questions in the chat. One is, you mentioned, this is from Demarius Boutros. You mentioned the important goal of starting trauma SUD discussions in primary care in hopes of reaching more patients, intervening sooner. Broadly, generally, how do primary care providers react to these initiatives? I find that primary care is universally quick to remain hands off.
Yeah, it's a great point. We can't just be burdening the primary care docs with having to now provide mental health care on top of assessing for whatever, medical conditions they have, that so I really feel like primary care practitioners are, but they are the point of entry. So it's I think more of a political or position on how do we get more care to happen in a primary care context. And there's been a lot of effort to try to do like for the expert, where you're providing integrated care within a primary care setting. We don't expect, I mean, if the primary care, even an additional screening for trauma or even substance, it's hard enough to get a substance use something in a chart. So I think you're absolutely right and it's not the primary care doctor's problem. It's more of our system. It's a systemic problem, but I think there is more recognition, for example, from National Institute on Drug Abuse and NIAAA that more resources have to go to those types of settings, lower barrier settings, to reach a larger slice of the pie than we're reaching with the specialty clinics. So people are doing this work. It's starting to happen, but it is challenging, absolutely. And I don't feel like we should be burdening the doctors to have to do the work. It's more like we need to find ways of integrating into those settings, and policy decisions have to be made to support that.
Yes, we prefer when the therapists do the hard work.
Yeah, well, that's our
Yeah.
training. So,
Um,
I, yeah, there's a Q&A question also in the webinar thing.
yeah, do you see that? Okay. I appreciate your observation that BPD is the result of trauma, not random or organically based. Can you recommend any resources, especially client-friendly resources that can expand on this?
So I cannot, other than the book, my book, probably there's stuff in there that where we talk about this, the kind of the decision making and thinking around those things. But it's a good question. Nobody's ever asked me that specific question to try to like think about what kind of resources. So I will think about that, but I don't have a better answer than what I just gave you.
Sometimes we use one of Bessel van der Kolk's articles on
Yeah,
developmental trauma disorder, which
yeah, yeah.
really talks about when people get this borderline personality disorder diagnosis,
Yes,
um,
yes.
how that tracks with
You're
CPTSD.
reminding me also the Julian Ford and Chris Courtois have a book that was recently updated, and we wrote a chapter in that book, and it's on complex trauma. And we wrote the chapter on substance use disorders, but I think that's probably a really good resource as well for that kind of language. And it's a very clinically oriented, it's chapters from different authors, but my guess is they would have stuff in there as well. Yeah.
Right. There's a question in the webinar chat. Any comment on psychedelic therapy?
Yes, thank you for asking. I didn't speak to that because I wanted to like make sure we wrapped up so that there could be more questions. But um, basically, same thing with cannabis. Like there's a lot of excitement about cannabis as a treatment for PTSD in some states, or it's even on a practice guideline. There's
Mm.
no evidence that cannabis itself is beneficial for people with PTSD. A lot of people with PTSD and substance use disorders do use cannabis, particularly to address the sleep problems that are very common in PTSD and substance use. And also from a harm reduction perspective, there's some idea that, oh, well, if you use opioids and you could start using cannabis instead, wouldn't that be a good, and maybe that is like, depending on the individual, maybe that is. Nowadays, the THC levels in cannabis are very high and like 100 times more than the weed of the 1970s. It's not the same drug. It's a chemical that is being promoted by the green industry, which is like the tobacco industry, which is like, and so I am very clear that, you work with your client around harm reduction and, if somebody's using something to sleep and that helps them, but perhaps you also have to look at how much they're using and whether that in and of itself is harmful. We're seeing huge increases in rates of cannabis use disorder and also the association with psychosis, which is not made up. And particularly in young people, very, very concerning. So I would say there's no evidence that I could stand behind that would suggest a positive benefit. That being said, depending on the individual case, you may assess that in the grand scheme of whatever else they're doing, that's not something you're going to. And most patients don't necessarily come in saying, I want to change my cannabis use and most of our clients use multiple substances. So that's thing one. In terms of psychedelics, there's this idea that you can have, and we have psychedelic assisted psychotherapy. There are some cases, for example, and there's a clinical trial happening in Australia that's being very well done, MDMA plus cope for people with PTSD and SUD. And how they're doing it is like there's 1 or 2 doses of the MDMA, which is an all-day thing where the therapist stays and does like some sort of processing work while the person is going through that experience. But they're very specific. It's not like microdosing psychedelics, will change the PTSD. And there's really very little evidence of the benefit of it. There's some idea that if you use a psychedelic, it might help hasten the processing work. So in careful combination with an evidence-based psychotherapy, there is some evidence that's kind of suggestive that it could be a positive thing, and people are testing it. But we have no clinical trials, and one of the problems with the psychedelic clinical trials is you can't get a really good comparison group. And we know that placebo is incredibly effective generally. So if a person believes that a person is getting the drug and they know they're getting the drug because it has a very specific physiologic effect. So they know there's no placebo. So I'm just concerned that the trials that are out there we don't have a really good comparison. So it's going to be hard to really assess. And then it's also very hard for people to you're not going to get a therapy that it takes 24 hours or 12 hours of a therapist's time to sit with an individual patient. So not very many patients are going to have access. Sorry, that was a long answer.
No, that's great. And along the lines of access, first of all, thank you for starting with a land acknowledgement and the acknowledgement of the lived experience of people in your trials, and particularly those folks who don't have access to good care, or
Mhm.
who maybe have access to care but get treated differently because of their backgrounds. And I was wondering if you could say anything about research specific to um, Black Americans, Latinx Americans, Indigenous people with the co-occurrence of SUD and PTSD.
Well, one of the things we know is that things like racial discrimination, of which people have like everyday discrimination, and also racial traumas, which were originally not included in DSM.
Yeah.
So you couldn't get a diagnosis of PTSD from experiencing some kind of a racial traumatic experience. That has been changing, and there's been a bit of work written on this subject now. And so I would look for Tanya Saraya's work on gatekeeping in the PTSD space and her colleagues. But we know that there's higher rates of trauma in Native American populations, and then the concept of historical trauma and how to work with that in this context. And it's just all of the subjects are highly relevant to those populations that you are just you know speaking to. And I think some of my junior colleagues and former students are now working on interventions that can be more culturally adapted. Although what we do see is that even though there might be diagnostic differences, and our Project Harmony study corrects for all of the measurement non-equivalence that comes, so we can have a better eye on which treatments might work best for which clients. We're not seeing that any one particular type of treatment is better for, a Black person versus a white person, but we also do know that there are fewer Black, providers from diverse backgrounds, and
Yeah.
that most people benefit more from having someone, or seeing more people that look like them providing the care. And so we do find that it's helpful to be in group, if you're in group, to be in groups where you feel like you can be, but the match of therapists. And so that's where, maybe treatment programs can really be more aware of like how to do better matching so that people can feel like their cultural backgrounds can be, and it's not that other people can't understand and we can think about our own cultural humility, but it can also be very helpful to feel like, well, you're being treated by somebody who has, you know, has a different way of being that is more, creates a more safe environment for you.
Yeah. Well, yeah. Well, and also if you're being, if you are a person of color being with historical trauma and racialized trauma being treated by a white person,
Yeah.
that's in the room, right?
Yeah.
If you provider, look like, even not on a conscious level, but
Right.
you look like potentially the people who have perpetrated me,
Yeah.
I think complicates the care. One last question, and then we're going to have to wrap up. It seems, this is from James, it seems in regards to substance abuse in this model, results seem to be more about reduction of
Yeah,
use,
that's
not
such a great
recovery.
point. So the Project Harmony 2.0 that we're doing, we are specifically focusing on recovery as opposed to just symptom reduction. And so that's part of the problem with clinical trials in general, is like you're picking a single primary outcome. So anybody who does comorbidity work, you're already like doing multiple outcome, PTSD and substance use. But they want to see like, have you reduced symptoms of the disorder? But on a broader scale, I think you're absolutely right that we want to be thinking more about all the other dimensions. So people that do clinical trials have already started to include more, recovery capital measures and well-being and wellness measures or quality of life, because really, like going back to that slide where I have the question mark for clinicians, those are the things that might matter to a client more than just did they have X% less of their PTSD symptom. Like if their recovery is improved, their quality of life is improved, their relationships are improved. That's probably I mean, that we know that's a better approach. So thank you for that question.
Excellent. All right. Well, I think that is all the time we have for today. Thank you, everyone, for coming. And thank you, Dr. Hien, for not only for this talk, but your compassion and advocacy for evidence-based and integrated care and all of the decades of work that you've done with people who have this difficult comorbidity. So anybody who is here who wants a CE or CME, you'll be getting an email from the email address that you registered from. So be on the lookout for that. And this recording will also be on our website under webinars. So thank you again and have a great afternoon.